Good evening, everyone. My name is Canon Dramar. I would like to take this opportunity to welcome you all to our first AASM Clinical Practice Guideline webinar series on oral appliance therapy. I'm an associate professor of medicine at the Mayo Clinic College of Medicine. I work at the Center for Sleep Medicine at Mayo Clinic in Rochester, Minnesota. I was fortunate and privileged to work as a task force chair for developing the guideline paper on oral appliance therapy. Today I'm joined also by two other panelists, Dr. Leslie Dort and Dr. Sherry Katz. Dr. Dort is a practicing dentist at Calgary in Canada, and Dr. Sherry Katz is a practicing dentist at Atlanta, Georgia. Both Dr. Dort and Katz have served in leadership positions within the American Academy of Dental Sleep Medicine. Next slide. As I mentioned, this is going to be the first of an ongoing many series of AASM webinars. The plan is to have each webinar come out within 2 to 3 months of a guideline paper coming out. The purpose of doing this webinar is to provide you all and the general public a little bit more insight into why and how these guideline papers and recommendations were created, hopefully to give you a little bit of a backstage information on what went on during this preparation process, and hopefully also to provide more ideas to implement the recommendations into daily practice. What we may not be able to cover are the actual practice guideline recommendations per se, but feel free to ask questions, as some of you have already done, using the chat button, and we'll try to answer those at the end of this series, webinar, and if not, we'll try to get you the answers posted on the website. As an overview for the next 20-25 minutes, this is what we were planning to cover. Briefly introduce the task force members, give an update and a history, provide a brief history and iron out the reasons in terms of the reason for updating the practice parameter, talk about the review of evidence evaluations, developing the recommendations, talk about some implementation ideas, try to wrap things up with some take-home points, and open it up to question and answers. And as I just mentioned on the previous slide, feel free to use the chat function to ask questions. So we'll try to reserve some time for some question and answers at the end here. So I briefly introduced myself, Dr. Sherry Katz and Dr. Leslie Dort. The other task force members were Dr. Christopher Lettieri, who's a pulmonologist and a sleep physician at Walter Reed Hospital at Bethesda, Maryland. Unfortunately, he's unable to join us today as a panelist. Dr. Ron Sherwin was the board liaison for this task force, and he's at the University of Michigan. Mr. Christopher Harrod and Dr. Shereen Thomas were the representatives from the AASM staff who did a fabulous job in helping us with collecting or doing the search, collecting the data, and doing the necessary analysis to help us to come up with a recommendation subsequently. So let me just in the next couple of minutes touch upon the history and the reason why we went ahead and updated our 2015 practice guideline paper. So the first reason is based on studies. So if you look at the first practice parameter that came out in 1995, they were only case studies that were used to make the practice parameters. Within 10 years, there was a little bit increase in the literature within the oral appliance therapy, and we had 10 level 1 studies that helped us to make the practice parameter recommendations in 2006. In the next 9 years, you can see that we had a significant increase in the quality and quantity of scientific literature. In fact, we had 51 randomized controlled trials, And so it made sense then to go ahead and use this higher quality data to come up with updated recommendations compared to 2006. The second reason is collaboration. So if you look at the practice parameter papers from 1995 and 2006, they were commissioned by the American Academy of Sleep Medicine, AASM, with input from the American Academy of Dental Sleep Medicine, AADSM. However, in 2015, the board of directors from both the organizations decided that it would be better to come up with an official joint guideline paper between both AASM and AADSM, which in fact makes sense because the intervention that's currently being used or looked into is oral appliance therapy. And that was another reason to go ahead and update the practice parameter. The third reason is moving from Oxford to GRADE as a way to process and assess evidence quality. So GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation. And we used a modified version of GRADE in this particular guideline paper. And as you can see in this particular slide, randomized controlled trials start off with a high initial quality of evidence, while observational studies start with a low initial quality of evidence. However, even if they have high initial quality of evidence, the studies could be downgraded based on the factors that are listed on the right side of the slide: risk of bias, inconsistency, indirectness, imprecision, or publication bias. So for example, if you have a randomized controlled trial that's not necessarily directly addressing a particular PICO question that we had in mind, though it starts off with a high quality of evidence, because of indirectness, it might be downgraded, and it might end up being at moderate or even lower quality if there were other factors that led to a downgrade, that led to downgrading the quality. This is one of the main reasons why we decided to go with randomized controlled trials in our search for evidence to develop our guideline paper. The only two PICOs where we didn't have randomized controlled trials and therefore went to observational studies are PICO number 7 and 11. And these are very well listed in the guideline paper, both in the methods section as well as in the results section. And as you can see, if you start out with observational studies with a low initial quality of evidence, it quickly gets downgraded to very low. And that was one of the main reasons why we decided not to go for observational studies except for PICO number 7 and 11. So as you can, this slide basically lists the final assessment of quality of evidence after the studies, those starting at a high initial quality of evidence based on randomized controlled trials could be downgraded to moderate, low, or very low. And as you can see out here, the final assessment of the quality of evidence after downgrading is how confident one is in the estimate of effect. So for example, if you take moderate quality of evidence, the true effect is likely to be close to the estimate of the effect, but there's a possibility that it could be still substantially different. And as you go down to low and very low, you can see that the true effect might be completely different from the estimate of effect. And so this gives you an idea in terms of the reasoning for downgrading and the final assessment in terms of the quality of evidence. And this is again also listed in the guideline paper as well. Using that is how we came up with our strength of recommendations, because we combine what we get from the quality of evidence along with assessment of the benefits and harms to come up with our overall strength of recommendations. So when we come up with our recommendation, we grade it as standard, guideline, or option using this table that's listed out here. So for example, if the paper or if the quality of evidence based on the previous two slides ends up being moderate and the benefits of that particular recommendation clearly outweighs the harms or burden, then it ended up getting a standard recommendation. So that's how you, as you look through the practice guideline paper, you'd see standard guideline or option, and that's based on this particular transparent way of doing things within our task force to come up with these recommendations. Now I'll pass it on to Dr. Leslie Dort to cover the next few, along with Dr. Sherry Katz to cover the next few slides out here.
Welcome, everybody. This is Leslie Dort here. While we were developing the recommendations and reviewing the literature, there were some problems encountered and issues to be considered. In some cases, problems or questions that we hoped to answer, but unfortunately were unable to because of the evidence that was presented, and then some issues that arose in considering implementation and best possible care for patients. And these included who should provide oral appliance therapy, what is actually a qualified dentist in the terms of providing oral appliance therapy, how does the severity of baseline obstructive sleep apnea affect the recommendations in this particular guideline, and do appliance types have an influence? And I'll pass it off now to Dr. Katz to start off on the next slide.
So who should provide oral appliance therapy? It was determined that oral appliance therapy should be administered by qualified dentists because oral appliance therapy requires dental-related technical skill, acquired knowledge, and judgment. Then it was determined that obstructive sleep apnea be diagnosed by the sleep physician and oral appliance therapy be prescribed by a sleep physician because obstructive sleep apnea is a medical disease that requires long-term medical management. So why a qualified dentist? And this was a major point in the task force job to determine this. And it was based on that oral appliances require specific dental knowledge and training. It's rare for undergraduate dental schools to teach dental sleep medicine, and therefore postgraduate education is required. Ideally, the American Academy of Dental Sleep Medicine's programs would be providing training equivalent to the American Board of Dental Sleep Medicine diplomate status. However, because of the limited number of diplomats, less stringent minimum qualifications were adopted. So beware that there's multiple for-profit organizations offering training programs that are typically product biased, and they may not be equivalent, and therefore we've determined that the programs be offered by nonprofit organizations. So how do you consider who is a qualified dentist? And we have three categories. One is certification offered in a dental sleep medicine by a nonprofit organization. The next one, the qualified dentist could be a dental director of a dental sleep medicine facility accredited by a nonprofit organization. And thirdly, the dentist has a minimum of 25 hours of continuing education in dental sleep medicine in the last 2 years from a nonprofit organization or accredited dental school. And they must have a valid state license and proof of liability coverage. And I'll pass the mic back.
So this is Leslie Dort again. One of the issues that previous guidelines have made some differential recommendations for the appropriateness of oral appliance therapy based on the severity of the baseline OSA diagnosis. However, the literature review for this guideline did allow us some sub-analysis based on achieving a variety of outcomes, such as an AHI or RDI of less than 5 or less than 10 events per hour, or reducing the AHI RDI to by more than 50% from baseline. And these are reported on in the manuscript. But the results in the studies that we reviewed did not allow analysis based on the severity of the baseline OSA. And so the recommendations do not specify treatment based on baseline severity of OSA. Another issue was that we addressed in this guideline was appliance types. There are multiple types of appliance. One, prefabricated, known as boil and bite devices, or over-the-counter devices, tongue-retaining devices, custom-made oral appliances that allow no adjustment to jaw position. If you can imagine, in this case, a CPAP machine that was only ever allowed to deliver one fixed pressure, say 9 centimeters, that's what number 3 is equivalent to. And 4, custom-made oral appliances that are adjustable. Another word that's used is titratable. In this case, the jaw position is adjustable by the patient to allow a variety of openings and therefore increase effectiveness. The literature allowed analysis based on appliance type, and custom-made adjustable devices were identified as the more effective devices for most outcomes. And so the task force adopted the AADSM definition of an effective oral appliance, and the guideline recommends a custom titratable appliance over non-custom devices for oral appliance therapy. Next slide, please. The basic qualities of an effective oral appliance are, one, that it is custom made from dental impressions, that it has 2 components, one for the maxillary teeth, one for the mandibular teeth, that it is adjustable, the jaw position is adjustable in less than or equal to 1 millimeter increments, that it stays in the mouth reliably, and that it holds its structural integrity for 3 or more years. The other issue that we'd like to address in this webinar are implementation ideas. Who should implement these recommendations, and what are the resources for implementing them in daily practice? So components of implementation are the sleep physician or physician and the dentist who does dental sleep medicine, who for best care will seek out qualified collaborators. And it's important to find opportunities to have conversations with each other. Sleep centers should refer patients to a qualified dentist, and dentists, patients should seek care from accredited sleep centers, and dentists must receive a prescription from a physician to treat. Now, there are a lot of shoulds on this slide, and questions about how to proceed to get the best process can be at least partially answered by some of the resources listed on the next slide. So here, with implementation requires a constant communication back and forth between dentist and physician to increase awareness on both sides of the collaboration as to the most current guidelines and recommendations and how those can be adopted and adapted in any particular practice situation to best serve the patients. There are some resources here. There are some policies and procedure templates on evolved sleep for physicians. Physicians can look at, or dentists can look and find accredited sleep centers at sleepeducation.org. Physicians can go to the AADSM website and to the Find a Dentist to look for dentists who have their diploma status. And in addition to these resources, for dentists in particular, many AADSM continuing education courses have sessions on how to establish and improve communication and collaboration with physicians in accordance with guideline recommendations. I'd like to pass it on now to Dr. Ramara.
Oh, thank you, Leslie. So to summarize a few things that's been discussed so far, I think we all agree that CPAP is still the first-line treatment for obstructive sleep apnea. However, if there is a patient who's intolerant of or unable to use CPAP, or for that matter strongly prefers going with oral appliance therapy, then at least his or her candidacy for oral appliance therapy should be further explored. And when this exploration happens and followed by further management, active collaboration should be occurring, as was discussed earlier on, between sleep physicians and qualified dentists to manage patients with obstructive sleep apnea on oral appliance therapy. The sleep physicians in this situation is usually responsible for diagnosing, treating, prescribing, and long-term management of obstructive sleep apnea, while a dentist is helping out and being responsible for fitting and delivering of an appropriate and a titratable oral appliance, along with adjusting the appliance to optimize the effectiveness to control and treat obstructive sleep apnea, along with helping to manage the dental-related side effects that might happen with the use of oral appliance therapy. Evolved Sleep, as was briefly touched upon, is a great website to check if you haven't tried it out. It's the webinar, along with the questions that are not completely covered in the question and answer session will be posted out here as well. And it's also a place where information is integrated. So you have links to the practice guideline paper. You have links to education materials that might be helpful for your practice. So it basically is an all-inclusive toolkit to help providers to provide the best quality of care to your patients. So if you haven't had a chance, check out this website. The other two links that's given out here are to the Journal of Clinical Sleep Medicine and Journal of Dental Sleep Medicine, where the practice guideline papers have been published. With this, I think we'll open it up to a live question and answer session. So please do use your chat function to ask questions. And Mr. John Heel, who's our staff representative from AASM, has been collecting all these questions. And so I'm just going to have him read out the questions for the panelists to address here at this point.
Thank you, Dr. Mar. One of the first questions we received is from a dentist, and they're asking how they should judge the success of their oral appliance therapy.
So that's a good question. Let me start off answering it, and then I'll probably leave it, see if Leslie and Sherry have things to add to it. So I think this is something that we touched upon during our webinar, as well as during in our practice guideline paper, because it was part of the PICO question in terms of trying to figure out how to follow up on these patients to assess for effectiveness. So at this point, I think we most commonly in practice at least use overnight oximetry studies. And of course, if you have an oximetry study that was done before the oral appliance, doing it after the oral appliance to assess effectiveness is one way. Of course, the gold standard is still an overnight polysomnogram study. In terms of data and thereby coming up with a recommendation, unfortunately, was very minimal, if at all any, and that's one of the reasons why we couldn't come up with a recommendation for the use of overnight oximetry study as a follow-up to assess effectiveness. So I think from a practice point of view, it might be reasonable to do or to use oximetry studies as long as you're comparing apple to apple. For example, if you're starting off with an overnight oximetry study along with a PSG, following the appliance therapy, you could consider using the oximetry as a way to follow up on and see if things are effectively being addressed. Of course, the confirmatory test still would be PSG, and again, this is definitely a room for further research to be done to come up with solid data to help us to come up with a better recommendation than what's been posted so far. I don't know, Sherry or Leslie, if you have anything else to add to that.
This is Leslie Dort here. One of the issues that we weren't able to address in this recommendation because there was no good quality evidence is a combination of outcomes to to judge, what is a definition of success beyond, reduction of the AHI or RDI. And this is perhaps an issue for future guidelines, and it's an issue that's patient-specific in some cases, the goals for a particular patient. And hopefully in the future we'll see some evidence to review that will give us some measures of quality in the treatment of obstructive sleep apnea outcomes with oral appliances. And as was mentioned in the recent quality measures paper by Aurora et al. in 2015, published this year, looking at what is considered, good quality outcome measures. And number 2 was improving quality of life, and number 3 was reducing cardiovascular risk. So hopefully, again, this will be future guideline work to integrate these kind of quality outcome assessments in an overall definition of success, which this particular task force was not able to accomplish.
Great.
All right, so a second question that we received. Can you discuss the use of pulse oximetry as a method of titrating the oral appliance?
And I think this is something I briefly touched upon with the last question. The overnight oximetry, again, for a lack of evidence, because that was PICO number 7. In fact, if you look at PICO number 7, that was part of PICO number 7. And in fact, there were no randomized controlled trials, not surprising, but there were no observational studies either to come up with a decent recommendation in the use of overnight oximetry studies. So, but from a practice pattern, from a clinical practice, I think it would be reasonable to use that to titrate things. Of course, it all depends on the degree of desaturation that was present beforehand to see if, as one is adjusting the oral appliance, if one is noticing a difference in the both the degree and the number of desaturation events on the overnight oximetry study. So as we all know, sometimes you don't see a correlation between the ODI and the AHI or RDI on a home sleep apnea testing. And so if that's the case, and or if the degree of desaturation is less to begin with on the initial diagnostic and a screening test, then it's less likely that the screening test with the overnight oximetry study might be helpful for follow-up. But those are factors that need to be considered as one looks to see whether to use an overnight oximetry study for subsequent titrations. From a cost-effective method, that seems reasonable to use that as a way. However, from a recommendation point of view from the task force, we were limited because of the lack of data to help us in that regard. Leslie or Sherry, is there anything you want to add to that?
No, I think you covered that well.
Yeah, you covered that well. I think that a lot of this goes back to emphasizing the importance of the communication between the physicians and the dentists on how the patients are titrated and how patients are handled also.
Yeah, that's a great point, and I think that's important. I think the collaboration between a qualified dentist and the sleep medicine physician who initially diagnosed the OSA and subsequently decided to go with the oral appliance therapy needs to be on a constant basis as one manages these patients. Absolutely.
Excellent. So another question we received, besides making sure that patients are using their AM positioners, what else can be done to prevent occlusal changes in patients using oral appliance?
Maybe I'll pass this on to either Leslie or Sherry to address.
Okay, this is Sherry here. Well, regarding the occlusal changes, there is in the included randomized controlled trials, there is evidence that changes do occur, but there were no randomized controlled trials that address strategies that work or do not work. So the task force could only make recommendations related to evidence that we were able to mine from these studies. So because there were no randomized controlled trials that addressed treatments, we could not address the issue at this time. So this is probably an area that will have more evidence in the future guideline work. And do you all have, I don't know if Dr. Amar or Dort has anything to add to that.
No.
No, I don't. Leslie, I don't know if there's anything else you want to add to that, or?
No, that seems sufficient.
Great. So, John, I presume.
I'm sorry. I had myself on mute and started talking.
Oh,
so
sorry.
this was touched on a little bit during the presentation, but it came in as a question, might be worth repeating. What's the best way to educate each other and work collaboratively in this, in a time when everyone is very busy?
Yeah, it's an important point to reemphasize, and I think it's easy to say let's work as a team and collaborate, but from a patient care perspective, that's probably essential. And I think the resources that's been listed in this webinar, along with the website links, hopefully should help us in that regards. And I think there's ongoing collaboration, though. Sometimes once you find your qualified dentist through the AASM from a physician's perspective, and the dentist finds someone using the AASM website, I think the patient, in order to make sure that the patient does benefit from this, the teamwork environment needs to be established. And I think most of us try to do that to the best of our ability. And I think as we do this more, I'm pretty sure we're going to find points or lessons that could be shared with others and help us to continue to collaborate even better. I mean, I think the task force itself, it's a good example of how well we ended up collaborating to come up with these recommendations, both two sleep physicians along with two qualified dentists working together to come up with this practice guideline paper. Maybe I'll see if Sherry or Leslie have further thing to add to this.
Leslie here. So it's nothing that the task force, looked at directly, but just anecdotally, the closer communication you have, so that there's a certain comfort level with just picking up the phone to discuss any particular patient or unusual solution or approach. I think the better it is for everyone. Sherry?
What I could add to that, as you said anecdotally, is try to attend conferences with your colleagues and call your universities and your sleep clinics, because most of them do have conferences, and it's an opportunity to sit down and discuss patient care and research together, and for better patient management, I believe.
Great points.
Great. So we have received a lot of questions. As I look over them, I think a lot of them would be difficult to answer as a live Q&A, but as Dr. Amar mentioned, we have every intention of addressing as many as we can and posting those answers on the Evolve Sleep and the AADSM websites. So I think for now, we should close out the live Q&A. If anyone has more questions, I encourage you to submit them via the chat. We will save those and answer them as best as we can.
Thank you again for all of you joining us, and it's been a pleasure. And I again want to thank the panelists, Dr. Dort and Dr. Katz, along with Mr. John Heel joining us out here for this particular webinar series. So thank you again for coming, and please do send your questions in, and we'll do our best to answer them and have it posted on the Evolve website. Thank you for coming.
Thank you.
Thank you, everyone.
Thank